Welcome, friends. We're going to start the session. So today is a small chapter. Usually the testicular cancer cases will not come for exam, but usually that will be going into discussion in cases of secondary hydrocele. As an hydrocele case, it can be a topic. So let us have a basic outline. It's a small chapter, just less than 1 hour chapter. Let us discuss. Cancer testis. The most serious point of this chapter is it is a disease very common in young age. Okay, the cancer testis, when we are discussing, by 20 to 40 years, seminomas mostly happen. Seminomas are happening, and less than 20 years, non-seminomatous tumors are going to happen. And less than 10 years, you are going to get, like Leydig cell and Sertoli cell tumors will happen. Leydig and Sertoli cell tumors. So now let us discuss about the tumors. Why the most important point about this is, in exam, you should think about a patient coming to you in a very young age, like 10 years, 20 years, 20 to 40 years. Some patient coming to you with a hydrocele-like thing, you should think of testicular cancers. So just a brief outline before going into the chapter. Let us have a brief outline about the classification of testicular cancers. Classifications of testicular cancer is germ cell tumors. There are basically two classifications: germ cell tumors and sex cord tumors. Sex cord tumors only we have Leydig cell tumor, which are all very, very rare. Sertoli cell tumor and gonadoblastomas. These are very, very rare tumors, and other type of tumors, others are like lymphoma, secondaries, all come under other types of rare tumors. So lymphomas and secondaries are coming under other type of tumors. In this chapter, we are going to discuss about the germ cell tumors. The germ cell tumors are of two types. They are seminomas and non-seminomas. So non-seminomas and seminomas. Non-seminomas include the following tumors. Why we are classifying them as seminomas and non-seminomas? Because of the nature of some property of these two tumors. So teratoma, embryonal cell cancer, choriocarcinoma, and yolk sac tumor. So these are the tumors which are actually in this chapter. So which is the commonest of all the tumors? Which is the commonest tumor? So if they ask you single specific tumor, means the commonest tumor is seminoma. But if they don't have seminoma, and if there is a choice of mixed tumor, most commonly we get mixed type of tumors. Mixed means mixture of seminoma and non-seminomatous components. So this is a basic outline. We should not go into the chapter without knowing the classification of testicular tumors. Seminomas are radiosensitive tumors. That is the most important point. Non-seminomas are non-radiosensitive. That is why they are classified into two categories: non-radiosensitive tumors. So let us approach this chapter more clinically now. Let us start with the clinical approach of testicular tumors. So usually the clinical history taking, clinical features, history of an young male coming to you with the complaints of swelling in the scrotum. That is a common presentation, swelling in the scrotum, which is painful or painless. Usually it is painless enlargement of testis. Painless enlargement of testis. Yes, very good. That is painless. That is correct. It is a painless enlargement of testis. Patients comes to you, or it can be due to a secondary hydrocele. There is a swelling. It can be due to secondary hydrocele. The patient may come to you with a swelling. So the common presentation is an young male. Please remember, testicular tumor is very common in young male. Is there any testicular tumor common in old age? Old age, above 60, if a patient is coming to you with a testicular tumor, none of these tumors will happen. Only one tumor can happen, that is Lymphoma. Lymphoma is the only tumor which can happen at 60 years. So please remember, the only tumor which can happen at 60 years or above is lymphomas, or some secondaries, secondary deposits from other tumors. Otherwise, above 60 years, you will never get a testicular tumor. So the most important point is, in exam, if you go and tell something like, this case is a case of testicular tumor in a 60 years male, and if you tell seminoma, naturally the examiner will get irritated. That is why I'm starting with the age. So the first important thing is, only for less than 40 years, you will see a testicular tumor. If a patient coming to you with a secondary hydrocele at 65 years, and if the examiner is asking a differential diagnosis, and if you tell for a 60 years male as seminoma, do you think naturally the examiner will be happy? He will immediately get upset. He will get upset that you don't know what is the age group of a testicular tumor. See, for remembering for your lifetime, let me tell you one important incident. Testicular tumor is always seen less than 40 years, and you can know very well, Swami Vivekananda, he died of testicular tumor with the metastasis. He had testicular tumor at around 35 years, and he died at around 39 years with the multiple mets. So today we have excellent treatment for seminoma, and Swami Vivekananda would have not died if we had Swami Vivekananda at this point of time. That much excellent prognosis is there for seminomatous tumors. So Swami Vivekananda died of testicular seminoma. Okay. So young males swelling in the scrotum is the commonest presentation. Do they have any other presentation? Usually they won't have any other presentation, but you can ask them for some history, they may tell you. So other positive findings that you should ask from them are, other history that you should ask from them are, they can have para-aortic nodes which will compress the IVC. See, these are all due to metastatic features. Para-aortic nodes compress the IVC and causes, whether you should ask history of bilateral pedal edema. Bilateral edema, call the wing it bilateral pedal edema, call wing the IVC compress panni, he can develop a bilateral pedal edema. So you should ask about that history. And when there is a lung mets, he can have hemoptysis, cannonball mets. History of any hemoptysis you should ask. Hemoptysis or cough you should ask from the patient. Okay, or any other swelling in the body. Ask for history of any other swelling. Where are the other swellings the patient will tell. Other swellings the patient may tell. Left supraclavicular node. He can even tell, sir, inge or katti irukku kaluthula, supraclavicular node, or abdomen la or mass mari irukku, para-aortic mass. So these are the other positive histories you should ask. You should provoke the history and get from the patient. Sometimes because of the para-aortic nodes causing enlarged IVC can get compressed. Patient may have bilateral pedal edema, hemoptysis, cough. All these are positive histories. And what are the predisposing factors history you should ask? So predisposing factor, the most common predisposing factor of seminoma is what? Not smoking. Not smoking is for CA-penis. Here, the most important predisposing factor. Not smoking. Smoking is only for cancer penis. What is the predisposing factor of testicular tumor? The most common predisposing factor is, what is it? Yes, the most common predisposing factor is undescended testis. Undescended testis. So will a testicular tumor is prevented by bringing the testis to the scrotum? By doing orchidopexy. Even by orchidopexy, the risk is not reduced. Even by orchidopexy for undescended testis, risk of cancer is not decreased. Is not decreased. So you should ask for the patients whether they had, yes, undescended testis. Cryptorchidism is correct. So undescended testis la kuda testis kondandu vachita kuda ergane nama surgery panni testis kondandu scrotum la vachalum they have risk factor is now present. So undescended testis, one of the important risk factor. Maternal estrogen. So maternal estrogen exposure. Okay, maternal estrogen exposure, number 2, and testicular feminization syndromes. Testicular feminization syndrome. Okay, very important one syndrome will develop this disorder. What is that? Klinefelter syndrome. So that is why Klinefelter patients, yes, very good, very good. Klinefelter syndrome patient, அதனால தான் நம்ம என்ன பண்ண சொல்லுவோம், அவங்களை ஆர்கிடெக்டமி பண்ண சொல்லுவோம். So Klinefelter syndrome patient should be done architectomy. If you don't do architectomy, they will develop a testicular tumor. So undescended testis on, even on orchidopexy, the still risk is there. So you should ask about history of surgery for undescended testis irukka kekano. And history of any trauma. Actually, trauma is not the cause of testicular tumor, but trauma brings notice to the patient. So trauma வந்ததுக்கு அப்புறம் அவன் நோட் பண்ணுவான், நமக்கு ஏதோ கட்டி இருக்கு அப்படி சொல்லிட்டு அப்புறமா பேஷண்ட் வருவான். So history of trauma is very important point. Another thing you should not forget. So what are all the predisposing factors of testicular cancer? Please don't forget these points. So இதெல்லாம் நம்ம கேட்டு முடிச்சிடுறோம். கேட்டு முடிச்சிட்டு now I am going to examine the patient. So short case, don't go for a detailed history and all. So you should only ask about positive history. So the swelling எவ்வளவு நாள் இருக்கு and what is the predisposing factors, that's all you should go for. Inspection of the local area. Inspection, you can see the testis, the scrotum is enlarged on one side. So the scrotum is enlarged on one side, you can notice very well, and one side it will be normal. And on examination of inspection, you should look for any other swelling. Apart from the testis swelling, you can see the testis is enlarged with the rugosity of the scrotum is disappearing, rugosity of scrotum not present. And you should look for any inguinal nodes on inspection. Inguinal nodes are usually not enlarged. Very important, not enlarged. So in the chapter final year, like in the node they will be expecting you. Inguinal nodes are not enlarged, but you can see an abdominal mass. So abdominal mass can be present. That is nothing but para-aortic nodes. Para-aortic nodes can present as a abdominal mass. So inspection la perisa onnu finding irukadu. You can only see an enlarged right side testis. That's the only thing. Okay. So let us see now what is the lymphatic drainage of the testis. Very important point in the chapter lay. In the concept da romba mukkiyamaana concept. Please don't make mistake in the exam. So testis is an organ of lumbar region. Actually testis inge da modalla irundhudu. So anga irundhu da adu descend ஆகி scrotum ku vandiruchi. So in the பக்கம் descend ஆகி scrotum ku vandiruchi na scrotum. Okay, this is the scrotum, right and left testis. So அங்க இருந்து வந்ததனால அவங்களுடைய lymph node drainage பாத்தீங்கன்னா that will be totally to the same place where it would have been present. So இதுதான் IVC. So இதுதான் aorta. So aorta. So testicular tumor வந்துச்சுனா இந்த node எங்க first spread ஆகும் அப்படின்னு பாத்தீங்கன்னா it will be actually இங்க தான இருந்தது. So spread will be to this place. So this is the nodal spread. This is called as interaortocaval node. Right testis spread ஆகிற இடம் interaortocaval node is the sentinel node of right testis. So right testis உடைய sentinel node என்னன்னு பாத்தீங்கன்னா interaortocaval nodes. Left testis உடைய sentinel node எங்க? Left testis. So left testis also spreads to the pre-iron para-aortic nodes. Left எங்க போகும்? Para-aortic nodes க்கு போகும். So right and left testis உடைய nodal primary spread where angle. So please remember, testicular tumor will spread only to, testicular cancer will spread only to interaortocaval and para-aortic nodes. Right side interaortocaval, left side para-aortic nodes. பக்கத்திலே தான் இருக்கு inguinal region, ஆனா அங்க போகாது. I told you cancer penis will spread to superficial deep inguinal nodes. But இங்க அங்க போகவே சான்ஸே கிடையாது. Testicular tumor will never go to inguinal mets are not seen. Inguinal mets are not seen. So இங்க போனதுக்கு அப்புறம் you are correct. After the para-aortic node போனதுக்கு அப்புறம் you know very well it will go to the cisterna chyli. Cisterna chyli spread ஆகும், அப்படியே போய் left supraclavicular நோடுக்கு போகும். This is a normal route of para-aortic nodes spread. But ஆனா inguinal node metastasis வராது. So typical clinical viva question, when will inguinal node mets happen? Inguinal nodeல எப்ப metastasis வரும்? Testicular tumorல இருந்து inguinal node metastasis எப்ப வரும்? Number 1, if I do a FNAC via scrotum, scrotum வழியா குத்தி இப்படி FNS எடுத்தா வரும். இல்ல number 2, incision made in the scrotum. Okay, scrotumல ஒரு incision போட்டு testis biopsy எடுத்துட்டேன் அப்படினா வந்துரும். Number 3, very high grade tumor, பயங்கரமான கொடூரமான tumor which has infiltrated the scrotal wall. அது வரைக்கும் வராது. Scrotal wall involve ஆனாதான் they will produce inguinal node mets. This question can be asked in Viva. So will a patient of testicular cancer develop an inguinal mets? Means usually not seen. But when you take FNAC via the scrotum or incision in the scrotum or high grade tumor which infiltrated into the scrotal wall, and the scrotum வந்ததுக்கு அப்புறம் தான் இந்த mets வரும். Otherwise, usually it will not produce inguinal mets. So please remember, if I am going to do something through the scrotum, it is called as violation of tumor principle. பெரிய பண்றீங்க நீங்க. Violation of tumor principle அர்த்தம். So therefore, what should not be done for these patients? Never ever take transcrotal biopsy. அதாவது எக்ஸாம்ல மட்டும் டிரான்ஸ்க்ரோட்டல் பயாப்சி எடுப்பன்னு ஒரு வார்த்தை சொல்லிட்டீங்கன்னா அடுத்த வருஷம் எக்ஸாம் அப்பியர் ஆகணும். அந்த வருஷம் நீங்க அப்பியரே ஆக முடியாது அப்படின்னு தான் எங்க காலத்துல. ஸோ டெஸ்டிகுலர் டியூமரை பத்தி டிஸ்கஷன் போகும்போது இஃப் அ ஃபைனல் இயர் ஸ்டூடெண்ட் டெல்ஸ் ஐ வில் டேக் எ டிரான்ஸ்க்ரோட்டல் பயாப்சி அப்படின்னு சொல்லிட்டாலே இட்ஸ் அ வயலேஷன் ஆஃப் டியூமர் பிரின்சிபல் அண்ட் எக்ஸாமினர் வில் நாட் லிஸ்ட் டு யூ ஆஃப்டர் தட் எனிதிங் யூ சே. அதோட நீங்க அடுத்த வருஷம் வாப்பான்னு சொல்லிடுவாங்க. அதுக்கப்புறம் பாஸே கொடுக்க மாட்டாங்க. So violation of tumor principle is a very important concept. Please don't forget. The examiners will be very much upset if you take transcrotal biopsy. So that is a very important thing related to the nodal spread. Nodal spread பத்தி தெளிவா தெரிஞ்சுக்கங்க. And coming to the testis. So testis is a basic anatomy. So testis is divided into the following layers. This is tunica albuginea. Okay, tunica albuginea layer which is encircling all the germ cells. அதுக்கு மேல this is tunica albuginea. It is covered by tunica vaginalis, two layers. This is tunica vaginalis. This is tunica vaginalis. So this is visceral layer. This is parietal layer. So these are the layers. Actually, hydrocele is a collection of fluid between the tunica vaginalis layers. Collection of fluid between these two layers is known as tunica vaginalis. Layer is called as hydrocele. So this is the normal layer. So now testis will not infiltrate the scrotum. Idan scrotum vechukongala. Cancer in the testis will not easily infiltrate the scrotum. இங்க இருக்கிற கேன்சர் பக்கத்திலே இருக்கிற ஸ்க்ரோட்டமுக்கு அவ்வளவு சீக்கிரத்துல போகாது because of the protective tunica layers. So இந்த tunica layer தாண்டி இந்த testicular tumor இங்க இருக்குல்ல உள்ள testis குள்ள இருக்கிற tumor, it will not come to the scrotum. So it will not so easily infiltrate the scrotum. So that is why the staging of testicular tumors, you should not forget the anatomy of staging of testicular tumors. You should not forget these layers. So this is a testis anatomy. Please understand the testis anatomy. So tunica albuginea, tunica vaginalis. So இங்க இருக்கிற டியூமர், இந்த இடத்துல இருக்கிற டியூமர் இங்க ஸ்க்ரோட்டம்க்கு அவ்வளவு சீக்கிரத்துல வராது. So it will not infiltrate the scrotum so easily. So please understand this point. So scrotumக்கு அவ்வளவு சீக்கிரத்துல it will not infiltrate because of the tunica layers are very thick layers. They won't allow it to go inside. So therefore the point you should not forget is tunica vaginalis. இதான் கேன்சர்னா ஃபர்ஸ்ட் கேன்சர் டெஸ்டிஸ்ல இருந்து tunica albugineaவுக்கு வரும், அப்புறம் வெஜினாலிஸ்க்கு வரும், ஸ்க்ரோட்டம்க்கு வர ரொம்ப 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 நாளாகும். ஸ்க்ரோட்டம்க்கு அவ்வளவு சீக்கிரத்துல வராது. ஸோ ஸ்க்ரோட்டல் இன்ஃபில்ட்ரேஷன் இஸ் ரேர். அதுக்கு முன்னாடி எங்க ஸ்ப்ரெட் ஆயிருக்கும்? இந்த ஸ்க்ரோட்டமுக்கு வர்றதுக்கு முன்னாடி it would have spread to the nodes. நோடல் ஸ்ப்ரெட் ஆல்ரெடி முடிஞ்சிருக்கும். ஸோ டெஃபினட்டா ஒரு பேஷண்ட் ஸ்க்ரோட்டல் இன்ஃபில்ட்ரேஷன் வராங்கன்னா ஆல்ரெடி அவனுக்கு nodal spread இதுக்குன்னு அர்த்தம். Please remember, it should have already having nodal spread. That much it is a stage-wise prognosis. So let us now go to the clinical examination. So inspection பார்த்தாச்சு. Now I am going to do palpation. So again, please remember on palpation, it is a painless mass in the testis. You can palpate, and very important, testicular sensation is absent. Testicular sensation is usually absent in these patients. So testicular sensation is a sickening sensation. Tap testicular sensation will be absent. But actually what new editions are saying, don't do testicular sensation test. Because the test is it unwantedly spread the tumor cells inside. So don't do testicular sensation. Now, don't do testicular sensation. Just examine the mass, explain about the mass, and look for epididymis. Epididymis thickening irka, and look for examine the spermatic cord for any induration. So you should palpate and look for spermatic cord induration. And always palpate inguinal nodes. Inguinal nodes will be negative only, but inguinal nodes are palpated. There are no inguinal nodes palpated. So the examiner will be happy. So then they will immediately ask you a question, why inguinal nodes are not palpated? Because you should tell immediately the spread of testis will be to the para-aortic nodes, not to the inguinal nodes. You will pass. Okay. So inguinal nodes are palpated, no nodes seen. And you should always tell about palpation of the para-aortic nodes. You will see the para-aortic nodes exactly on the umbilicus area. So on the umbilical area, you will see a para-aortic mass. So para-aortic nodes are palpated as a mass around the umbilicus. Mass around the umbilicus is palpated as para-aortic mass. They are fixed retroperitoneal nodes. They won't be mobile. So fixed retroperitoneal, they won't be mobile. So this you must mention. And never miss the look for examination of left supraclavicular node. Supraclavicular node not palpable. I palpated for left supraclavicular node, it is not palpable. And the examination of the RS, I don't see any of pleural effusion or anything. So RS la cannonball mets varum, you can see on X-ray. But RS examination should be mentioned. Okay, RS examination should be mentioned. CNS also, it can produce brain mets, and it can produce brain mets related features. So all the places you should examine and tell the patient, tell about the clinical examination findings. Only perisa finding irukadu. The chapter lay discussion on the full and full investigation treatment. So now diagnosis, you are having a doubt as a right testicular cancer for a patient. Right testicular cancer is your diagnosis. Now tell me the differential diagnosis. If you are going to tell right testicular cancer, immediately the examiner will ask you, what are all the differential diagnoses of this case? Can you tell me what are the differential diagnoses? Number one, commonest name, epididymo-architis. That is the commonest differential diagnosis. So, but the point is, epididymo-architis will be painful. Number two, hematocele or pyocele, they also will be looking hard. But both these cases also will be painful. They also will be painful. Okay. Syphilis causing secondary hydrocele. Syphilis with a secondary hydrocele is another differential diagnosis. This is painless. So syphilis leon, testicular cancer leon, there is no testicular sensation found. Syphilis and secondary hydrocele is fourth one. So fourth one is look for any other causes like traumatic injuries, traumatic architis. So these are other differential diagnoses, but please remember all these are actually differential diagnoses of secondary hydrocele. So whatever secondary hydrocele you know, you can put them as differential diagnosis for testicular cancer. So now the question starts, actual viva question starts from now. இப்போ நீங்க சொன்னதெல்லாம் basics. இதுல எந்த டவுட்டும் வரக்கூடாது. Testicular cancer inguinal நோட்ல drain ஆகாது, para-aortic நோட்ல தான் drain ஆகும். ஒரு முக்கியமான பாயிண்ட். Testicular cancer வருதுன்னா undescended testis இருக்கான்னு பார்த்திருக்கணும். ரெண்டாவது முக்கியமான பாயிண்ட். இப்போ முக்கியமான பாயிண்ட், how to diagnosis of testicular cancer. So diagnosis of testicular cancer very very important. முக்கியமான பாயிண்ட், biopsy அப்படின்ற கான்செப்ட் எடுத்துட்டாங்க. Biopsy is no more needed. is no more needed. முன்னாடி ஒரு கான்செப்ட் டிஸ்கஸ் பண்ணுவோம். என்ன சொல்லுங்க? transinguinal biopsy அப்படின்னு ஒன்று எடுப்போம். transinguinal biopsy னா what is that maneuver called as? அந்த மேனுவர் நம்ம புக்ஸ் எல்லாம் படிச்சிருப்பீங்க. அந்த மேனுவர் இஸ் கால்ட் as சிவாசு மேனுவர். அந்த மேனுவரை இப்ப எடுத்துட்டாங்க. அந்த புக்ல this is no more done அப்படின்னா என்ன? சிவாசு மேனுவர்னா என்ன? See, this is a picture showing you the patient with the spermatic cord. இதான் spermatic cord, இதான் testis in the scrotum. And in the testis தான் எனக்கு கேன்சர் இருக்கான்னு டவுட்டா இருக்கு. ஸோ என்ன பண்ணுவோம் அப்படின்னா, முன்னாடி நாட் டன் நவ், முன்னாடி என்ன பண்ணுவோம்னா, இங்க ஸ்க்ரோட்டம் வழியா தான் பயாப்சி எடுக்கக்கூடாது இல்ல. ஸோ அதனால இங்குனல் ரீஜன்ல இன்சிஷனை போட்டு இங்குனல் கெனால் வழியா இந்த ஸ்பெர்மட்டிக் கார்டை வெளியில இழுப்போம். ஸோ வெளியில இழுத்துருவோம். ஸ்பெர்மட்டிக் கார்டை பிடிச்சி இழுத்தீங்கன்னா டெஸ்டிஸ் வில் கம் அவுட் லைக் திஸ். அப்போ நம்ம அந்த டியூமரை எடுத்து பயாப்சி அனுப்புவோம். எடுத்து பயாப்சி இங்குனல் ரீஜன் வழியா எடுத்து பயாப்சி அனுப்பிச்சு அது டியூமர்னு வந்துச்சான்னு பார்ப்போம். ஃப்ரோசன் செக்ஷன்ல டியூமர்னு வந்துச்சுன்னா அப்படியே தூக்கி ஹை ஆர்கிடெக்டமி பண்ணுவோம். இங்க we will do a high inguinal architectomy. ஹை இங்குவினல் ஆர்கிடெக்டமினா டீப் ரீம்புக்கு மேல போய் கட் பண்ணணும் ஸ்பெர்மட்டிக் கார்டே. ஸோ 2 சென்டிமீட்டர் அபவ் டீப் ரிங்ல போய் we have to cut and take it out. நெகட்டிவ் வந்துச்சுன்னா டெஸ்டிஸ் தூக்கி உள்ள வச்சிருவோம். இதுதான் ஒரிஜினல் சிவாசு மேனுவர். இப்படிதான் முன்னாடி எல்லா டெஸ்டிகுலர் கேன்சர்ஸும் பல வருஷமா பண்ணிட்டு இருந்தாங்க ஆப்ரேஷன். இது இனிமே கிடையாது, இந்த கான்செப்டே கிடையாது. பயாப்சியே டெஸ்டிகுலர் டியூமருக்கு வேண்டாம். இந்த வயசு பசங்க 20 வயசு பசங்க ஒரு மாசம்னு வந்தாங்கன்னா இது டெஸ்டிகுலர் டியூமரா தான் இருக்கும். அப்படின்றதுனால the first done investigation for these patients is what? Patient coming to you with a suspected testicular tumor, the first done investigation is ultrasound of the scrotum. அதுல ஏதாவது சஸ்பிஷியஸா இருந்தா investigation of choice is MRI of the scrotum. That is enough. இதை வச்சே கண்டுபிடிச்சலாம் டெஸ்டிகுலர் டியூமர்னு. A mass, a heterogeneous mass in a young age should be testicular tumor only, no doubt. Investigation of choices MRI scrotum. What else should do next? So MRI scrotumல testicular tumor னு கொடுத்துட்டாங்க. அடுத்து வேற என்ன இன்வெஸ்டிகேஷன் பண்ணலாம்? Ultrasound is the first done. Investigation of choices MRI scrotum. Next I should go for tumor markers. So tumor markers are elevated because they are germ cell tumors. So beta HCG is elevated in choriocarcinoma. Choriocarcinoma beta HCG will be 100% elevated. 100% elevated. Where is tumor marker? Alpha fetoprotein is elevated in yolk sac tumor. Yolk sac tumor, it is always elevated. And the non-seminomas, usually non-seminomatous tumors, they are usually mixed components. So non-seminomas will have increased beta HCG and increased alpha fetoprotein. Seminomas, முக்கியமான point என்ன? Seminomasல and another tumor marker elevated in non-seminomatous is increased lactate dehydrogenase. See, seminomas will have no tumor marker. Seminomasல tumor marker is pure seminomasல. Pure seminomasல tumor marker not elevated. Yes, diagnosis சொல்லும்போது right side testicular tumor without any evidence of clinical meds அப்படின்னு சொல்லிடுங்க, அவ்வளவுதான். So right side testicular tumor without any evidence of clinical medicine கொடுக்கணும். I'm telling you, usually examல testicular tumor வைக்கவே மாட்டாங்க. அந்த வயசு சின்ன பசங்க வந்த உடனே பிடிச்ச ஆபரேஷன் தான் பண்ணுவாங்க. அதனால hydrocele case they will go for discussion, that's all. When you tell this is the case of hydrocele அப்படின்னு சொன்னோனே what are the differential diagnosis சொல்லுவாங்க. அப்ப நீங்க differential diagnosisல நீங்க கமிட் ஆவீங்க பாருங்க, அப்ப பிடிப்பாங்க. then only they will catch you. அப்பதான் testicular tumor குள்ள போவாங்க. So testicular tumor is a question which is made by you for the examiner. Okay, so tomorrow probably we will discuss hydrocele, not the oral cancer, because I thought of finishing hydrocele and testicular tumor, it will be common. So tumor markers are elevated in pure seminomas. Pure seminomas tumor marker is not elevated. So pure seminomas tumor marker is not elevated. That's முக்கியமான point. Seminomas tumor marker elevated. Pure seminomas tumor marker not elevated. So this will be done for all the patients. And please remember, latest update is Biopsy not needed. Biopsy not needed. Anyway, biopsy not needed. So biopsy எந்த வழியிலுமே நீங்க பண்ண வேண்டாம். Biopsy தேவையில்லை. So நம்ம next step என்ன பண்ண போறோம்? Biopsy பண்ணல. Next treatment of choices. Directly I will go for the surgery known as high inguinal archidectomy. See, this is the protocol. Now, after the investigation is done, I go for a high inguinal archidectomy via 2 centimeter above the deep ring. I should cut the spermatic cord. Spermatic cord 2 centimeter மேல போய் கட் பண்ணி தூக்குறேன். கட் பண்ணி தூக்கிட்டு then I am going to send it for biopsy. So testicular tumor கட் பண்ணி biopsy அமிச்சாச்சு. Biopsy report comes as seminoma ன்னு வரலாம், இல்லனா non-seminoma ன்னு வரலாம். So something it will come. So whatever it is, the first treatment is high inguinal archidectomy. Is there any other investigation I should do apart from the following tumor investigations? Ultrasound scrotum, MRI scrotum, tumor markers. This is the investigation. Is there any other investigation done? I told you, para-aortic nodes may be enlarged. So para-aortic nodes, what is the investigation of choice? It is CECT abdomen and pelvis. CECT abdomen and pelvis is done to look for para-aortic nodes. Please remember this. So para-aortic nodes, we may do CT scan and pelvis. CT scan, abdomen and pelvis will be done to look for para-aortic nodes. But whatever it is, after confirming that's a tumor, whether it's a seminoma or non-seminoma, we have to go for further management. Actually, there is a small net delay. I am in a hotel for a class. So this hotel, the net is very slow. I am using my mobile data only. So the answer what you are telling is coming after some time. So very good. Some of you are answering very fine. Very good. So but anyhow, this problem here is I could not immediately get the results from you. Seminoma, non-seminoma, archidectomy done. What are you going to do for the para-aortic nodes now? Now seminomatous tumors having para-aortic nodes, what will you do? And for non-seminomatous tumors having para-aortic nodes, what will you do? Okay, what will you do? So para-aortic nodes and seminomas and non-seminomatous tumors, you should not forget, seminoma is an excellent radiosensitive tumor. So radiotherapy is the treatment choice for radiotherapy to the para-aortic nodes. So radiotherapy kudutale and the node allan dissolve aidum. Aduve podum. No need of surgery. And for advanced cases, advanced para-aortic nodes cases, advanced cases, I will also add up chemotherapy. So chemotherapy, seminomas la kudupom when the tumor is advanced cancers. Seminoma la advanced cases we give pleomycin, etoposide, cisplatin, BEP regimen. Bleomycin, etoposide, cisplatin. Please remember, bleomycin, etoposide, cisplatin. This is the 3 drugs we will give in those patients with the seminoma. Bleomycin, etoposide, cisplatin regimen is given for seminomas which are advanced cases. So on the local stage based, they are not asking questions, but I will tell you afterwards for an extra edge. For UG level, this is enough. Seminomas la high inguinal archidectomy mudichi biopsy seminoma vanda, I will go for radiotherapy to the para-aortic nodes. Whereas non-seminomas are not sensitive to radiotherapy. So what should I do? So non-seminomatous tumors are tumors which are less than 20 years, guys. They are the guys who are less than 20 years. So now I am going to do what? I am going to do the surgery now known as retroperitoneal lymph node dissection. Retroperitoneal lymph node dissection should be done for these cases known as RPLND. I should open and remove all the nodes. And even in those cases, advanced cases will need chemotherapy. Advanced cases, chemotherapy is given for those patients with the same BEP regimen. So bleomycin, etoposide, cisplatin is used for advanced cases. The carry home point is Seminomas na, I can easily treat them only with radiotherapy. Whereas non-seminoma, I should go for a major surgery known as retroperitoneal lymph node dissection. In the chinna pasangalukku in the retroperitoneal lymph node dissection pandradhula, what is a major disadvantage? What is a major problem which can happen when I'm going to go and remove all the retroperitoneal lymph nodes? What is a major disadvantage that will happen? I may injury to, yes, sympathetic nerves. Results in what problem? The nerve எடுக்கும்போது நான் sympathetic nerve அடிச்சிருவேன். So என்ன ஆயிடும் பேஷண்ட்டுக்கு? They develop damage of nerve urgencies. இல்ல அந்த அளவுக்கு எல்லா நர்வெல்லாம் கட் பண்ண மாட்டோம். நியூரோஜெனிக் பிளாடர் வர அளவுக்கு கட் பண்ண மாட்டோம். அதனால தான் சொல்றேன் சின்ன பசங்கன்னு சொல்லிட்டு nerve urgencies கட் ஆயிடும். So கட் ஆச்சுன்னா what will happen? Retrograde ejaculation வந்துரும். They won't have antegrade ejaculation. So retrograde ejaculation can happen in those guys. So retrograde ejaculation வந்துரும். So they cannot have a therefore because of retrograde ejaculation they will go for infertility many times. Therefore we have to be very careful when we are retroperitoneal lymph node dissection. Retrograde ejaculation can happen. So usually what they were doing to prevent this infertility problems, they are doing now sperm bank. Sperm bank ne இவனுடைய sperm எடுத்து சர்ஜரிக்கு முன்னாடியே ஸ்டோர் பண்ணிடுறாங்க. So sperm can be stored for many years போல இருக்கு. So they can be stored for some years so that after marriage ஆனதுக்கு அப்புறம் அந்த sperm எடுத்து female partner கொடுக்கிறதுக்காக sperm bank is done for these patients. For future purpose. பின்னாடி ஏன்னா அவனுக்கு அதுக்கப்புறம் ஸ்பெர்மே இல்லாம ஆயிடலாம் இல்ல ஸ்பெர்ம் ரெட்ரோகிரேட் எஜாகுலேஷன் ஆயிடலாம். ஏன் ஸ்பெர்ம் இல்லாம ஆகலாம்னா ரெண்டு ரீசன். ஒன் டியூ டு ரெட்ரோபெரிட்டோனியல் லிம்ப் நோட் டிசெக்ஷன். ஈவன் ரேடியோதெரபி கொடுக்கும்போது கூட the remaining test whichever is present will become sterile. So therefore usually before orchidectomy we will collect the sperm and store them in the sperm bank. So done for future purpose. Otherwise they will never get a babies in future. So sperm bank related points are not mentioned for G level, but it is little extra age. Okay. So this is a very important point. So let us see some important situations for me. So this is one of my patient. You can see here, I am operating for a secondary hydrocele here. This is a case I'm operating for a secondary hydrocele. It's actually one of the 25 years boy. You came to me with a secondary hydrocele. Ultrasound அனுப்பியிருந்தேன். Ultrasound, they told it is a normal testis and they told it is a clear fluid. Therefore, I very confidently, you can see I'm just opening it with the hydrocele. It's a medicos brother. So, a doctor thambi. So, and the doctor angada irundapla. So, he's also observing what we are doing there. I am very carefully opening the hydrocele routinely as usually we do. So, open பண்ணிட்டு fluid எல்லாம் let out பண்ணிட்டு, and now you can see. See, I'm now going to open the hydrocele with the help of 11 size blade. So let out the fluid. So straw color fluid is coming out. Straw color fluid is coming out. So naturally, I also thought, okay, it's an hydrocele. Adukapram dhaan problem start agudhu. Now I am going to open the sac. Open பண்ணி பார்த்தா testisல ஒரு mass. This is a 25 years male who came to me with a testicular mass. எடுத்ததுக்கு அப்புறமா fluid எடுத்ததுக்கு அப்புறம் பார்த்தா ஒரு hard mass இருக்கு. நானும் அதை தேடி பார்க்கறேன். அதுக்கப்புறம் அந்த mass குறையல. So I thought there is some problem inside. So therefore I am going to open it now. I am going to open it now. So everything is video taken. Therefore we are going to take it opened. So open பண்ணி பார்த்தா இந்த picture பாருங்க. பெரிய testicular tumor. So it is not even infiltrated the tunica vaginalis layer. Tumor is inside the testis. So அதனால என்ன பண்ணேன்? I just see the picture. The testis is fully enlarged. And on cut surface, you can see the tumor is present inside. So I have violated the tumor principle here. So இப்ப பாருங்க, this is a procedure shown here is called as retroperitoneal lymph node dissection. All the lymph nodes from the para-aortic and IVC area is completely removed. And this is a picture showing you retroperitoneal lymph node dissection. So all the nodes should be removed in non-seminomatous tumors. Very important. Please remember, all the nodes should be removed in non-seminomatous tumors. So therefore, the point you should not forget here is, for a UG level, you should not forget the basic things. So this is a picture video showing you what I showed you now is a classical case of secondary hydrocele presented, the tumor presented as a secondary hydrocele. That's the case now. So now I have violated the tumor principle. Violation of scrotum. What should I do now? இப்போ நீங்க பாத்தீங்களா இந்த பேஷண்ட்டுக்கு என்ன பண்ணிருப்போம்? I have now by accidentally opened the scrotum. Now I have to give, if it is a seminoma, I should give radiotherapy given to inguinal nodes and iliac nodes also. Okay, நான் ஓபன் பண்ணதுனால கொடுக்க வேண்டியதா இருக்கு, இல்லைன்னா தேவையில்லை. நான் செமினோமேட்டஸ் டியூமர்ஸ்ல என்ன பண்ணிருக்கணும்? நான் ஓபன் பண்ணதுனால I have to go for inguinal block dissection of the அந்த inguinal nodes ஃபுல்லா எடுத்துருக்கணும். லைக் சிஏ பினிஸ்ல பண்ற மாதிரி தேவையில்லாத வேலை பாருங்க. டெஸ்டிகுலர் டியூமரை வந்து நான் ஹையர் டிரான்ஸ்க்ரோட்டலா வராம trans inguinal vandha, that tumor would have not gone to the inguinal region or would have not gone to the iliac region. So unwantedly now I have to send the patient for radiotherapy if he is a seminoma, but luckily that boy is a seminomatous tumor, so he went for inguinal and iliac node radiotherapy. Non-seminoma vandha, we have to go for inguinal block dissection. Please remember, this concept is called as violation of scrotum. This is most important thing, you should not forget this. So that staging, now staging of testicular tumor is not like other staging. Staging is, what is that staging known as? TNM-S staging. TNM-S staging. It is not TNM staging. Testicular cancer staging, TNM-S. What is T1? What is T2? What is T3? What is T4? T1 is tumor infiltrating up to the tunica albuginea layer. And the testis and the tumor, idan testis now. The testis the tumor has come up to the albuginea layer, that is known as T1. Tumor which has gone up to the tunica vaginalis layer is T2. Tumor which has next go to where? Angar the tumor has gone to the skin, scrotal skin, that is T3. Angar the tumor has started infiltrating into the spermatic cord. The tumor infiltrated into the spermatic cord. Simple staging. So tumor infiltration to tunica albuginea, tunica vaginalis, and the layer தான் just நீங்க T stagingன்றது ஒண்ணும் கிடையாது, லேயர் தெரிஞ்சா போதும். இங்க இருந்து albuginea, அங்க இருந்து vaginalis, அங்க இருந்து scrotum, அப்புறம் அப்படியே spermatic cord. So this is T1, T2, T3, T4. Then coming to N1, N1, N2, N3. Okay, N1, N2, N3. Paraiotic mass less than 2 centimeter. Paraiotic mass 2 to 5 centimeter. Paraiotic mass size வந்து 5 சென்டிமீட்டருக்கு மேல பெரிய மாஸா இருக்கு. So paraiotic mass is more than 5 centimeter. So paraiotic clinically palpate பண்றோம். All these are clinical examination. Clinical N1, clinical N2, clinical N3, clinical T staging, clinical N staging அப்படின்னு சொல்றாங்க. But actually these are all not clinical staging. Most of the time we need to do investigations for clinical staging. We cannot know the layers. So though it is said as clinical N staging, very difficult to palpate the number of mass. Most of the time this is done with the help of CT and MRI. And M staging is what? M1A, M1B. M1A is pulmonary mets. See, pulmonary mets irundha kuda we can save the patient by giving radiotherapy in a seminoma. So Swami Vivekananda would have not died of pulmonary mets. Radiotherapy kudutha nalla irundhirupanga. So M1B is diffuse mets. Okay, diffuse mets. So M1B is other places, whereas visceral mets to other places. This is called as a classical M staging. And don't forget this T staging: albuginea, vaginalis, spermatic. Sorry, I have changed it wrongly. So first is spermatic cord, adukapram da scrotum. Okay, T3 is spermatic cord, adukapram scrotum. T3 is spermatic cord, T4 is scrotum. This is the order of T staging. But TNM staging la final year students therinjikku thevilla. It is not asked for your exam, so no need to know. Just for completion sake, I am telling you, in a theory exam you can write it. So theory la you can write. Adukapram S stands for serum tumor markers. So you have to measure the S1 for tumor markers. Adu mattum therinjikonga podum. S stands for serum tumor marker values. Tumor markers, 3 tumor marker பார்க்கணும். LDH, HCG, alpha fetoprotein. இதை வச்சு we have S1, S2, S3. 3 types இருக்கு. So this is TNMS staging. So TNMS staging is a staging used for scrotal cancer. So it's a very important update. Just remember it. So tumor marker diagnosis gives out the very important for follow-up. Follow-up, we should keep following the tumor markers, LDH, HCG, alpha fetoprotein. Follow-up, if tumor marker is elevated, increasing tumor marker, I should immediately do what testing? I should immediately do PET-CT scan to look for mets, distant mets. I should look for PET-CT to look for the distant mets. Okay, this is a very basic chapter. Don't forget testicular tumor. Yes, any doubts? Yeah. External iliac nodes ரொம்ப difficult palpate பண்றது. See, palpate பண்ணோம்னா inguinal ligament இருக்குல்ல அதுக்கு மேல palpate பண்ணணும். Where will you palpate means இதான் scrotum, இதான் inguinal ligament. Inguinal ligamentக்கு மேல ரொம்ப deep palpationல you can see the nodes. இங்கே nodes. In the iliac fossa, they present as iliac mass. Right iliac fossa mass உடைய differential diagnosis படிச்சிருப்பீங்கல்ல. Right iliac fossa mass, it's a differential diagnosis. ரொம்ப பெருசா இருந்தாதான் you can palpate. Iliac nodes can be palpated in the right iliac fossa or in the left iliac fossa. So right iliac fossa or left iliac fossa, you can palpate the iliac nodes. So they are usually palpated above the inguinal ligament. So inguinal ligamentuக்கு மேல தான் அது இருக்கும். Inguinal ligamentuக்கு கீழே you will not palpate. They will palpate it above the inguinal ligament. So iliac nodes are usually palpated above the inguinal ligament. You can palpate as a mass. Yeah, this is true. I will send. I will put in the group. Very good, very good. KP Naveen. Retrograde ejaculation is a very important complication. You should not forget. So are you clear? This is a simple chapter. In concession, so in concise form, I want you to remember the basic points in testicular tumor for a final year student. The testicular tumor carry home points for a final year student are, don't forget the carry home points in a testicular tumor. Testicular tumor will spread sentinel node of testicular tumor is para-aortic nodes. இது மறந்துடாதீங்க. Para-aortic and intra-aortocaval nodes. It does not spread to, it will not spread to inguinal nodes. இது ரொம்ப முக்கியமான point. It not spreads to inguinal nodes. இதெல்லாம் நீங்க மறக்கக்கூடாத points. Not spreads to inguinal nodes. Okay, so first point. Then venous spread அந்த அளவுக்கு கிடையாது. Venous spread like renal cell cancer will not be. Hematogenous spread is there. It spreads by hematogenous to distant places. So venous spread now you are asking about like growing into the veins, it is not there. So like renal cell cancer எப்படி vein-ல வளருமோ அந்த மாதிரிலாம் வளராது. It will spread by blood. Hematogenously it goes to the lungs and other distant places. That type of spread is there. So sentinel node மறந்துடாதீங்க. And don't forget the age group. Age group less than 10 years என்ன டியூமர் வரும்? Germ sex cord tumors. Sex cord tumors. Ledic cell tumorல என்ன சிம்டம் வரும் patient? 10 வயசு பையன். Ledic cell tumorலாம் ரொம்ப ரேருங்க. 5 வயசு பையன் எப்படி வருவான்னா with the hirsutism. முடிலாம் பயங்கரமா வளர்ந்து pubic hairலாம் வளர்ந்து தாடிலாம் வளர்ந்து வருவான். Pubic hairலாம் வளர்ந்து. So masculinity, early masculinity will be there for Ledic cell tumor. Sertoli cell tumor எப்படி வருவாங்க 10 yearsல? Sertoli cell tumor patients will come to you with a gynecomastia. Gynecomastia and voice will be like a female voice. So அந்த மாதிரி வருவான். So Ledic cell, Sertoli cell tumors. Sertoli cell பொண்ணு மாதிரி வருவான். Ledic cell tumor ரொம்ப அக்ரெசிவா பையன் மாதிரி வருவான். Okay, that is very important. So Sertoli cell tumor, Ledic cell tumor, age group 10 years kulla. 10 to 20 years la non-seminomatous tumors. More than 20 years you get seminomas. 20 to 40 years seminomas. And above 60 years it is lymphomas. So age vachi neenga confirm age sambandhama they will ask you. About the age related questions they will ask you. Testicular torsion will be very painful. They will not be kept for exam. The testicular torsion la kai வைக்கவே முடியாது. பயங்கர பெயினா இருப்பான். Patient will not be kept for your exam because within 6 hours you need operation. Testicular tumor la varadu. Don't get confused. Testicular tumor la வைக்க மாட்டாங்க. Testicular tumor is a differential diagnosis of architis. That's all. Otherwise, it's not to be mentioned. So, and biopsy is no more done. அது ஞாபகம் வச்சுக்கோங்க. Biopsy is no more done. எந்த மாதிரியும் கிடையாது. Transinguinalum கிடையாது, transcrotalum கிடையாது. எல்லாமே abandon பண்ணிட்டாங்க. MRI is enough to investigation of choice. And tumor marker is investigation of choice. Okay, tumor marker MRI பண்ணா போதும். No need of biopsy. Treatment of testicular tumor is what? High inguinal architectomy. High inguinal architectomy பண்ணிட்டு we have to treat the nodes. Seminoma இருந்ததுனா it will respond very well to radiotherapy. Radiotherapy to nodes. Non-seminoma இருந்ததுனா it will respond to retroperitoneal lymph node dissection. And chemotherapy BEP is given for advanced cases. Advanced cases like node பெருசா இருக்கிற node எல்லாம் கூட N3 cases also we will go for this advanced cases. So this is about the testicular tumor. So please don't forget testicular tumor and spermatic penile cancer ரெண்டுமே எக்ஸாம்ல டிஸ்கஸ் பண்ணக்கூடிய டாபிக்ஸ் and both of them can come for you as a short note. ரெண்டுமே ஷார்ட் நோட்டாவோ இல்லைன்னா ஒரு வேற 2 mark கொஸ்டின்ல கூட sometime they will ask you about this type of tumor. So please don't forget testicular tumors. Any other doubt you have in testicular tumors? Please tell me. Yes. Some of you have posted in the question and answer. You don't post in question and answer. You should post in the chat only. Radiotherapy, yes, Resu has asked what is the exposure of maternal estrogen means. Mother would have been given maternal estrogen like hormones during the pregnancy time. That is medical drugs, some drugs given during the mother when she is pregnant at that time. That is called as maternal estrogen. So Chivasu maneuver என்றது inguinal region ஓபன் பண்ணி inguinal region வழியா டெஸ்டிஸ் மேலே இழுத்து பயாப்சி எடுக்கிறது. அது இப்ப பண்றது இல்ல. Chivasu maneuver எக்ஸாம்ல சொல்லாதீங்க. It is not done now. Yes, it is not done. Don't tell in the exam. Gist of radiosensitive and radioresistant tumors. Radiosensitive, radioresistant tumors எனக்கு சர்ஜரியில வர்ற டியூமர்ஸ் தான் தெரியும். நிறைய ஆர்த்தோலாம் நிறைய ரேடியோசென்சிட்டிவ் டியூமர்ஸ்லாம் இருக்கு. You should read from others. Surgery பொறுத்த வரைக்கும் seminoma is very radiosensitive. Squamous cell cancers எல்லாம் ஓரளவுக்கு radiosensitive. So radiotherapy, chemotherapy, எந்தெந்த ஆர்கன்ஸ் இருக்கு அந்தந்த டியூமர் you should, when you are reading, you should understand. Otherwise we cannot know everything. அதாவது காமனா ஒரு டேபிள் மாதிரிலாம் நீங்க ரேடியோதெரபிஸ்ட் தான் கேட்கணும். எங்க சர்ஜரியில அதெல்லாம் வராது. சர்ஜரியில அந்தந்த டியூமர்ஸ் டிஸ்கஸ் பண்ணும்போது some tumors are very radiosensitive, some tumors are not radiosensitive. Radiosensitive seminomatous are radiosensitive. Therefore, no need of retroperitoneal lymph node dissection. Radiosensitive tumors க்கு radiosensitivity கொடுத்தாலே சூப்பரா கரைஞ்சிரும் டியூமர். Non-seminomatous tumors க்கு radiotherapy resistant இருக்கனால we have to remove it by surgery. So whenever radiotherapy is effective, that is the best easy treatment. இல்ல best treatment இதோட easy treatment. பெருசா நம்ம சர்ஜரி எல்லாம் பண்ணாம அழகா டியூமர் எடுத்துடலாம். We have not done retroperitoneal lymph node dissection in seminomatous. We have done only radiotherapy for seminomatous tumors. Non-seminomatous tumors we will do radiotherapy. Testicular secondaries can be from various other cancers. Where cancer testicular secondary ரொம்ப rare. For example, even prostate cancer can produce testicular secondaries, or from cancer from other organs can spread like lung, liver க்கு போற மாதிரி testis க்கு சில பேருக்கு secondary வரும், but they are all very rare. Okay, so just for completion sake. Okay. So this is about the testicular cancer. No, epigastric mass கிடையாது. Periumbilical mass, not epigastric mass. It will be seen at the periumbilical area, not in the epigastric. Umbilical mass you can put a DD as this testicular cancer, not epigastric. Epigastric mass on the pancreas is epigastric mass, not this. Okay. Okay. See you next class. Probably tomorrow we might be having hydrocele class. Oral cancer potrunda. I thought finishing of hydrocele will be covering the ingnoscrotal topics together. So tomorrow we will try to have hydrocele. Net problem. If net is fine, we will discuss. Okay. So don't worry, we have a clinical case discussion on epigastric mass later. Very thin patient, you will see the palpate, you can palpate the mass. So பெரிய மாஸா palpate ஆகும். அவ்வளோ நோடு இருக்கும். 5 centimeter மாஸ்லாம் பார்த்தீங்கன்னா அந்த அம்பிளிக்கல் ஏரியால ஒல்லியா இருக்கவங்களுக்கு தொட்டு பார்த்தாலே அந்த மாஸ் தெரியும். ஈவன் ப்ரொட்ரூடிங் அவுட் ஆஃப் த பவல். அயோட்டாவே பால்பேட் பண்ணலாம் ஒல்லியா இருக்கவங்களுக்கு. ஸோ அப்போ பேராய்டிக் நோட்ல நல்லாவே பால்பேட் ஆகும். ஓகே, பை. தேங்க்யூ.